So welcome everybody. I would like to introduce you to Dr. Ruth Lanius, MD, PhD. She's a professor of psychiatry and is the director of post-traumatic stress disorder research unit at the University of Western Ontario. She established the Traumatic Stress Service and the Traumatic Stress Service Workplace Program. These services specialize in treatment and research of post-traumatic stress disorder and related comorbid disorders. She currently holds the Harris Woodman Chair in the Mind-Body Medicine at the Schulich School of Medicine and Dentistry at the University of Western Ontario. Her research interest focuses on the study of the neurobiology of PTSD and the treatment outcome research examining various pharmacological and psychotherapeutic methods. She has authored more than 150 published papers and chapters in the field of traumatic stress and is currently funded by several federal funding agencies. She regularly lectures on the topic of PTSD nationally and internationally, and she has recently published a few books. One of them that we already know about is Healing the Traumatized Self, Consciousness, Neuroscience, and Treatment with Paul Fruin. And there are two other books, and that she will talk to us about these two books. So I don't know if we can introduce those two books, just a little nutshell right now.
Sure, absolutely.
Yeah.
Thank you so much for your introduction, and it's such a pleasure to see you again.
Thank you, Ruth.
I so enjoyed teaching for your institute last year, and I think we had a wonderful audience who was so interested in the topic and really wonderful discussion periods. So it's great to see you again and continue our discussion on trauma and dissociation.
Such an honor to have you with us. It really is a privilege for us and for our students who follow us. And what's the name of the recent book that just came out?
The recent book that's just been published, it's actually two books. The first one is a text, and it's published with Bethany Brand, Hugo Schielke, and Francesca Schiavon. It's called Finding Solid Ground, and it's really a book that focuses on how do we treat complex patients that we get stuck with in treatment. Mm-hmm. And so we focus on the critical importance of dissociation. We give a lot of role play scenarios. How do we approach difficult situations? And then the second book is a workbook, and it's published with Bethany Brand and Hugo Schielke. And it really takes clinicians and people suffering from post-traumatic stress and dissociation through specific exercises that they can help to find solid ground. So really come back and be able to live in the world with some self-compassion and seeing the world as a safer place.
Thank you. Thank you for presenting these two new books. I have my own copies, so I hope to have them autographed when we meet in person, probably next year in Spain, hopefully.
It'd be wonderful, yeah.
And we have the upcoming second edition of the training. We worked together last year with Dr. Ruth Lanius here at the Four Cycles Institute in Barcelona. And starting this October, you could sign up. You have the chance to join the training that we have entitled this year, Restoring the Self with Dr. Ruth Lanius. Dr. Ruth Lanius and our institute have prepared this hybrid training. This means you have access to 5 master classes. We decided to ask Dr. Lanius to pre-record the theoretical presentations because we know it's exciting to have them live online, but it's so rich and so much material for you that we wanted you to have these for some months to study. So we recorded 5 master classes with Dr. Lanius. And then once you come into the course, you watch these lessons 1 per week, takes 1 hour for you. And then you come each week, and the schedule is published on our website, to a live online direct Q&A session or experiential exercise or combined session with Q&A and exercises with Dr. Ruth Lanius. Then in addition to that, you have those that are recorded and will be posted, of course, and you have 3 months of time to study them, to apply for getting your certificate. And you have several peer-reviewed articles written and authored by Dr. Ruth Lanius and her team. And then you can opt to receive your CPD certificate from our institute. So if you want to join us, you're still in time. We'll publish the link at the end of this interview. In case you want to join us, please do. You can start in October watching the master classes and join us in November 2022. So you can begin and participate in this growing professional international community of clinicians learning with Dr. Lanius about treating PTSD and dissociation. So thank you very much. And I will now invite, ask some questions for Dr. Ruth Lanius to open up this topic. So Ruth, please mention of your understanding of what is trauma.
That's a great question, Enrique. And I think as a field, we struggle with what really is trauma, right? And so the way, I think we think about trauma is that there's the large T traumas, right? For example, physical and sexual abuse that really go hand in hand with how trauma is defined in the DSM, right? So really being hurt physically or sexually, and this would be a large T trauma. But we also know as clinicians that small T traumas, as we call them, so repeated emotional abuse, for example, being told as a child, you're no good, you're a terrible person, I don't like having you around, I wish I had an abortion, right? Those small T traumas, with ongoing emotional abuse, of course, also do a lot of damage. And then I think we can't think about trauma without thinking about attachment, right? Because the attachment relationship and a secure attachment relationship really lays the foundation for us knowing what we feel, for helping us know what other people feel, and for our whole emotional development. And if we don't have a secure base, as John Bowlby talked about, our emotional development is affected because we don't feel safe with our caregiver, especially with a caregiver with whom we have a disorganized attachment. So here, our caregiver is both our only source of safety often, but also a source of threat. And so it becomes very, very complicated. And the mind can't really cope with this. And so often, this is where dissociation starts, where we get this split, right? Part of us only remembers the safe parts of our caregivers, and the other part remembers the threatful associations with the caregiver, because keeping all that in one sort of field of consciousness would be way too stressful. And so we split. And so if we've had a disorganized attachment like this, if our caregiver has also been a source of threat, our emotional development is significantly affected. And we will be cut off from our emotions often. We will have difficulties knowing what other people feel. We will dissociate because it is too painful to be, with the knowledge of our caregiver being unsafe. And this also puts us at risk for later development of post-traumatic stress, when we experience physical or sexual abuse.
Mhm.
And so it starts us off with a vulnerable brain, which then, is at greater risk to additional traumas, both large T and small t traumas.
Let me see if I understand well. So, if the attachment of early childhood does not provide enough safety, this in turn creates vulnerability for individuals that exposes them to posterior eventual events that may harm them and create other kind of trauma. Is this what I'm understanding?
Absolutely. That's very well said, Enrique. Thanks for your elegant summary.
I'm trying my best. Thank you. And from this place, of course, you already mentioned that when trauma happens, we dissociate.
Yes.
In many different ways. But could you elaborate what is dissociation? Is there a definition about it?
I think broadly, dissociation is a psychological escape when no physical escape is possible, right? When we're trapped with the unsafe, inescapable stressor, then the only way we can distance ourselves is through a psychological escape, which is dissociation.
So it's like the mind at work trying to prevent pain, felt pain?
Absolutely. So it's the brain, mind, and body helping to decrease pain, intense emotions, knowing something that is too painful to know, or just kind of losing our sense of time, because having a sense of time would be unbearable. So it's really important, I think, to think about dissociation in different dimensions.
Exactly.
And dissociation is not one thing. It is a psychological escape, but it can happen through very different ways.
Yes.
And
can you share with us these categories? Yes.
Absolutely.
Yeah.
So dissociation can affect different dimensions of consciousness to protect us at the time of the trauma. But if we try to function in the aftermath of trauma, it really becomes difficult often. So the first dimension that's very affected by dissociation is the dimension of time. And often when we're in a traumatic event, we lose the our sense of time. We don't know how much time has passed. And often that's a blessing. For example, if we're kidnapped or if we're in a situation of chronic childhood trauma, we forget how much time has passed because that would be unbearable. But in the aftermath of trauma, if we lose our sense of time, and if we don't know if 10 minutes have passed or if 2 days have passed, it becomes very, very difficult to function in daily life, right?
Right.
The other dimension that's often affected in dissociation is the dimension of the body, right? Because we know from Bessel van der Kolk's work, the body keeps the score, the body carries so much pain. And that's why when we've been traumatized and the stressor is inescapable, we disconnect ourselves from our body and from the pain. And often people will describe that, they don't actually feel that their body belongs to them anymore.
Mm-hmm.
And again, at the time of the trauma, this is a great way of coping. For example, I have a patient that was repeatedly gang raped, and she describes herself being up in the tree, looking down at this body being raped. Mm-hmm. And this is what helped her to survive. But in the aftermath of trauma, and when she came for treatment, she was completely disconnected from her body. She couldn't feel anything, positive or negative. And so life becomes very unfulfilling when you're completely numbed out and you can't feel anything. And often you don't feel in control of your ability to move either. And so really learning to re-inhabit the body in the aftermath of trauma is really critical, and we will learn different ways of doing this.
And when you say this, you are referring to trauma-informed ways, trauma-informed adaptations of clinical work.
Absolutely. So this whole course is trauma-informed. We see everything in context of traumatic experiences and really understand why people are experiencing certain symptoms and certain feelings or lack of feelings or lack of movement or too much movement. And we understand it in context with their experience, both their attachment experience, but also their traumatic history experience. And that's how we talk about healing. We understand, where it's coming from, and keeping that in mind, how we can move towards healing and living a life worth living.
Thank you. I have one question for you, and it's about helping clinicians develop a stance that's as a psychotherapist, which stance to have when facing traumatized clients in such a way that provides care for both of the dyad, the client and the therapist, and to decide which intervention is the right one, because often I've been through peers in the community. Many of my peers have expressed frustration when their techniques are not working, or where the client is reluctant to adopt or accept the intervention. So, do you have something to say about this that could be within the framework of what we're doing?
Absolutely. And this is really what this course is about. It's about an integrative approach to trauma treatment. And I encourage people to get knowledge of as many techniques as possible, because I think the future of trauma treatment really is knowing when we use what and for whom. And so I think to go into the relationship, which will protect both the client and the therapist, is best in a non-judgmental and curious way. And to really help understand together with the client what's happening. And to really have the client be in control and see us as therapists as coaches. We're helping the client really get in touch with their own strengths. And I'm always so impressed how resilient my patients are, right? And I always think, my God, they're so much more resilient than I am. And so it's my job to help them access their resilience, which often they feel detached from. So it's letting them really get in touch and taking control of their own healing. And us as therapists, just being in the background as a coach, supporting them, seeing them, hearing them, and help them realize their full potential.
Absolutely.
And I think to do this, the more techniques we have available, the better. And here I also want to focus on top-down approaches and bottom-up approaches, and really developing an elegant way of combining the two approaches. And so top-down approaches, of course, relate with working with thoughts, helping people make meaning. But often, people have done a lot of work with their thoughts and meaning making. And they come into our office and they say, yeah, I know this wasn't my fault. I know I should not be ashamed. I know I shouldn't feel guilty, but I can't stop feeling it. And they feel it on a visceral level. They feel like they're, being torn up inside by those intense feelings. And this is where I think we need to combine the top-down approaches with bottom-up approaches, right? So bodily-based approaches, where we work with those intense visceral sensations, specific forms of trauma processing, for example, EMDR or deep brain reorienting, where we can target those visceral sensations experienced on a bodily level. And then, of course, also often when people have been traumatized, they couldn't complete the action that they wanted to complete at the time of the trauma. And so helping people to complete the action, for example, completing an active defensive response, pushing off their rapist in the form of somatic experiencing or sensory motor psychotherapy, often completing the action you couldn't at the time of the trauma also leads to resolution of those visceral sensations and really brings online feeling positive, feeling triumph, as Pierre Janet would have talked about, and really seeing yourself differently in this world.
That's great. That's great. So when you started your journey to doing this, I have to say to the audience, in case you don't know it already, that Dr. Ruth Lanius is not only a scholar, but she's also a clinician and a researcher. So from this stance, I would like to ask you, Ruth, if you can share with us, how did you approach this subject from all these facets that make your work what it is right now, what is flourishing in the world?
I think I've always been a clinician at heart. And the way I got interested in trauma was actually during my first year of clinical practice. And I started my residency in psychiatry, doing a month of psychiatry. And even though the patients weren't labeled as trauma patients at the time, they were trauma patients. And I spent a lot of time talking to them, really trying to understand, their first person experience. And I absolutely loved working with them because I could see so much resilience and so much capacity to change. And at the same time, I was also very interested in brain research. And so I thought, how the brain, mind, and body adapt to trauma is so amazing. While working with traumatized individuals, at the same time, I'd also like to understand what's happening in the brain, because we need to know that to develop more treatments, but also to reduce the stigma. And so this is how I started in this field, and I've learned so much from my patients. I'm so grateful to my patients, and they've really guided all the research our group has done.
Wow. And from this place, what do you think is the role of neurofeedback in trauma treatment from your experience?
I think neurofeedback is another very important adjunct approach to the treatment of trauma. And what I love about neurofeedback is that you're targeting the brain directly, right? We're now understanding how some of the firing of the brain is adaptive to the trauma, but not adaptive to living in a safe world. And so we have to help the brain readapt to safety, because it was great adapting to constant threat, but to heal, we now have to help the brain adapt to safety. And through neurofeedback, which is a form of biofeedback, where on a computer screen, you get feedback about your brain waves. Again, you take your own control, you take your own healing into your hands, and you now know that you can actually retrain your own brain to quietening down and really adapting to safety. And what I've seen therapeutically is that neurofeedback can really facilitate all the other approaches that we use, because it helps shift the brain to safety. And the more we're able to shift the brain to safety, the better all the different techniques that we use will work.
Yeah, thank you. And for instance, when working with trauma patients, could you give us just a few examples of when is the right time to use EMDR, for example?
Yeah, when do we use EMDR? That's the $100 million question, right? And again, I think we have to personalize that. And I think the short answer is, in order to benefit fully from EMDR, you have to be in your body and you have to be aware of what emotions you feel. And you have to be able to stay at the edge of the window of tolerance during trauma processing, right at the edge. If you go outside the edge, if you have too much hyperarousal or too much hypoarousal, we as clinicians see that the processing stops, right? And people just loop. They either numb out or they get so hyperaroused that they can no longer process. So I think the art is to have a patient have enough skills to have bodily awareness and capacity for emotion regulation and emotional awareness, that when we process, we stay right at the edge of the window of tolerance and we don't push them outside the window of tolerance. And I think if we can manage that with a client, then we can do EMDR very effectively.
Either in hyper and hypoactivation states, but keeping them present enough so the person can track themselves. Yeah, good, very good. And for example, a somatic experience, traumatic experiencing, is it good for numb states or those kind of dissociative states where people don't feel their bodies, or?
Absolutely. Some of Peter Levine's somatic experiencing techniques, especially for freezing states, and often our patients have freezing of the diaphragm, right, where they have trouble breathing. And so he has certain techniques, for example, where he gets people to chant, or he calls it wooing as well. So really resonating that diaphragm through, for example, woo, right? That can really resonate that diaphragm and get people out of freezing states, especially a frozen diaphragm. And we talk about this in the course. So that's one example where somatic experiencing, I think, can be very helpful.
And same with mindfulness-oriented treatments, right? How do you propose mindfulness to be presented or adapted in a trauma-informed context?
Absolutely. And that's a great question. We know that all treatments we use for trauma need to be titrated, right, for each client and personalized for each client. And so this also goes for mindfulness, where, a lot of our traumatized clients can't be mindful for, prolonged periods of time that are used in the standard mindfulness protocols. And so sometimes we have to start with very small increments of mindfulness, maybe 15 seconds, 30 seconds. And again, it needs to be personalized to the client through feedback, through, checking in with the client. What works for you? What's too little? What's too much? And this also goes for mindfulness of the body, right? The body scans. The body is a terrifying place after trauma. And so we have to titrate it. And again, we have to keep the person present and within the window of tolerance when we engage in the different mindfulness exercises.
Wow. So I just want to thank you so much. This has been such a lovely time to introduce what the workshop or the training holds for participants. And I really hope that we get the chance to deepen our knowledge as we go through the training with the participants, as they go through the master classes, and then join you and me for the live online direct calls where we will have Q&As, and it will be translated into Spanish simultaneously for Spanish speakers on a special translation channel, but it will be taught in English. And I want to also celebrate that we have a partnership with Newman Institute in Mexico City, and we are cooperating together to share this training with their subscribers. So that's also important because information needs to reach Latin America from this very informed researcher and clinician that like Dr. Ruth Lanius is. and such a privilege to have you and hold this training together on our platform, Ruth.
Thank you so much, Enrique, and it was such a pleasure seeing you again today. And I really look forward to learning together. I think this is what it's all about.
Yeah, in the last edition, I was so amazed at how the community participated from more than 19 countries, and it was so rich and so enriching. So I hope this time, and I'm sure it will bring us there, because this cannot be otherwise. These are challenging times, as many people have noticed. And we hope to bring this awareness and learning some skills together to empower clinicians to deepen their awareness of trauma and expand their skills on trauma treatment in the company of somebody like Ruth Lanius and her team. Thank you so much.
Yeah, I think it'll be a wonderful community.
It is. Thank you. I hope so too. So thank you.